Good morning, everyone, and welcome to the WPS presentation on chronic care management services provided by hospital outpatient departments. My name is Ellen Barra, and I'll be one of your presenters for today. We also have my friend and colleague, Mary Muko, who will be watching our chat function, and either she will be interrupting with questions or will be providing those questions at the end of the presentation. We also have multiple other members of our provider outreach and education team on this call today to assist with any technical difficulties, finding handouts, etc. And then finally, we have Dr. Joelle Vahakas, who is one of our contractor medical directors and is the lead medical director for our chronic care management and depression screening innovation challenge project. And she'll be talking to us a little bit about the value of this particular program. We are scheduled for an hour and a half today. We wanted to make sure that we had enough time to answer any questions that you have on chronic care management services. If we don't have as many questions, we may not go the full hour and a half. So let's jump in then to our presentation. Well, the first slide that you have here is just our disclaimer. And basically what this says is that if you've been with Medicare any length of time, you know that Medicare rules can change. This presentation is as accurate as we can make it as of today. You do want to be watching any changes, any change requests, any publications by CMS that could possibly change the information that we provided for you today. We will respond to questions based on the information that you're giving us, but of course the Medicare rules are going to determine the final coverage, and then any documentation, should we request it, would determine payment for this particular service. And the last line there, CMS does prohibit recording of this presentation for profit-making purposes. So if you're recording, we would ask that you stop. We are recording the presentation, and we will have it out on our topic center under the training, under encore presentations. We should have that out there by Monday or Tuesday of next week. So if you want someone else in your office to take a look at it, you want to listen again, you should be able to do that. And then we will also publish the fact that we have put that out there. The recording itself will be in a YouTube video. So what is our objective here for today? Well, we want to provide you information on the value of chronic care management services, and Dr. Vlahakis will be discussing that for us. We also want to provide you with the rules and regulations concerning how you can provide this service, how Medicare reimburses for this service. Hospital outpatient departments specifically are one of the providers that CMS allows to submit claims for this service. And so we'll talk about how the clinical staff of an outpatient department of a hospital, how the outpatient department of the hospital can bill for those services, and then also how that clinical staff can be part of the office, the provider itself, physician or practitioner, how that clinical staff can be part of providing that service under that practitioner itself. So our agenda here for today, again, is we're going to talk about the value of the program, the rules and regulations, and then we're going to open it up for questions. This is sort of a new service for hospital outpatient departments, and we want to make sure that you have all the information you need so that if your clinical staff are providing these services, you can get reimbursed for these. So let's talk first about chronic conditions. As you can see up on your slide, this provides you with information on the number of patients that have two or more chronic conditions. and 2 or more chronic conditions is required for the patient in order to submit for chronic care management services. As part of chronic care management, that umbrella term, there is chronic care management, complex chronic care management, and then principal care management. We're going to concentrate our discussion today on the chronic care management because that's what a hospital outpatient department can submit. So you can see when you're looking at this slide the different percentages of patients within our jurisdictions that could qualify for chronic care management service. We're not getting anything near this rate. When we're looking at the information, the data that we have gathered, the number of patients who are receiving chronic care management is very low in comparison to those patients who are eligible for that or who could receive that. And again, Dr. Vahakas is going to talk to us about the value of this, but chronic care management can really make a difference in your patients, in their health care, in their quality of life, etc. So we want to make sure that you have the information so that you can expand the number of patients to which you're providing this service. And for a hospital outpatient department, one of the ways that you can assist your hospital is in providing these services to prevent readmissions back to the hospital, back to the emergency department. What we have seen so far in our data is that as the number of chronic care management services go up, the requirements or the claim submission for emergency department visits and for hospitalizations have actually gone down. This picture that you have up on your slide right now is from the Area Deprivation Index. And the Area Deprivation Index is really just a picture. And when you go actually into the Area Deprivation Index and you can do a search just in your internet provider in your search field and can find this, and then you can kind of break it down a little bit into your particular states. In some cases, you can go into your different counties. But what you see on here is all of this red area. Well, the red area is what is called the area deprivation, where patients do not have necessarily as much access to providers and are not receiving as much care as maybe people within the blue areas. And that's another goal of our innovation project, is to increase the units of service, the chronic care management services that are provided to these beneficiaries within these high area deprivation index. These patients, because of socioeconomic status, healthcare availability, all kinds of different things, are not receiving the care that they need. So chronic care management can really be a very valuable step in helping those patients to receive medical care and helping those patients to improve their quality of life, to possibly get rid of some conditions that they have, etc. So I'm going to now turn it over to Dr. Joelle Vahakas, who will talk to us about the value that chronic care management can bring. Dr. Vahakas?
Thank you, Ellen. So I have had the good fortune to land on a team with people like Ellen and Mary, but my background is actually very different. So I'm an internist and a pediatrician whose heart was in primary care for a good long time. I did both private practice and then segued into rural health and really enjoyed that. And I've spent the last few years doing hospice and palliative medicine. But the thing that I can definitely say about all these experiences is that a big part of what we did was try to keep patients out of the hospital, try to manage conditions rather than have the conditions manage the patients. And I also have a soft spot in my heart for hospital outpatient departments because that was me for the last few years. I worked for a big hospital system, and if I did inpatient or outpatient, we were all part of the same system. So definitely want to make sure you all get the support that you need. So chronic care management is a wonderful program within the Medicare space and world. And it is specifically available to patients with two or more chronic medical conditions that are expected to last 12 months or more and impart some degree of risk for the patients. It is a different approach to care than is typical for what I learned in medicine. So when I was coming up through training, everything was very problem focused. You had an assessment and a problem, and then you made a plan. Well, when I got to hospice and palliative medicine, it was different. Suddenly, I didn't have to have, say, a 6-minute walk test in order to get my patient oxygen. All I had to think about was, gosh, they probably need that thing. Let's proactively look for that. Well, this chronic care management takes a page out of that book, meaning to say that it's a proactive approach to the patient's health, not just what they need right now because they have a problem, but how can we best make that patient's health model be different than that they need to come in with issues every time. It's holistic. So it looks at the patient not only in the context of the illness itself, but also in the context of family and more importantly, community. And that's where the strength based model of care comes from. You got to love a model that instead of um, searching for what you don't have, works on what you do have. What do we already have in the community that we can call upon to really bolster those efforts we are making to try to keep the patient as healthy as possible? It is a bit of an investment for both patients and providers, and we'll talk about that. But when we have this kind of approach to care, what we find is we're also very good stewards of those Medicare dollars, resulting in fewer emergency room visits and fewer hospital stays. Lest you think I'm simply about the dollars, I will tell you that I've never met a patient in the hospital setting who was glad to be there. Emergency room visits, they're extremely disruptive. Hospital stays are even more so. Um, People have families, pets at home, people they worry about. They're often, even as patients with chronic illness, the caregiver for someone else. So understand that we want to keep people out of those environments because it's not good for them either. One of the ways it's not good for them is that it is often associated with higher costs when you go to the emergency room or need a hospital stay. Even though there's some out of pocket costs for patients with this program, my colleague Ellen has calculated out that one hospital copay alone, one hospital stay, could pay for 5 consecutive years of chronic care management. So, um, I think understanding those things helps you discuss this with your patients a little bit better. You know what I was really surprised about with chronic care management because I worried very much about burnout for providers. I've been in, the throes of the pandemic trying to manage all of that. A lot of outpatient departments have gone to telemedicine. They've had to be very, very flexible, and they are working really hard. How can we ask them to do one more thing? Well, one of the primary reasons is because providers and your offices are doing a lot of this work anyway. You are already working hard to keep people out of the hospital. You're already working hard to make sure people get their medications and the correct ones. This allows you to be reimbursed for that work, and that's wonderful. I think also one of the things that really contributed to my quality of work life in a negative way was all the different places my patients went to get care aside from me and having to keep up with that. That's fragmentation of healthcare in its finest. And it is really, it adds to your work burden as a primary care provider. If your patients aren't doing that, you have more interaction with them through your office and clinical teams. It does make your life a little bit better. In fact, some of the providers tell me that they now have more time for in-person visits and they're able to appreciate the clinical skills of their staff and teammates, which is really a nice way to feel unburdened by so much put on you. So overall, it's also a better experience for providers. I'm not suggesting that this is the cure for burnout. Very few things are. It's too simplistic for that. But it might contribute to a better quality of work life for all. Next slide. All right, so there are a lot of challenges. In fact, we're having a whole conversation about this. I've been working on the slides for barriers to chronic care management, and I'll tell you just the high notes here. So identifying patients who gets chronic care management can be challenging. Do you use your electronic medical record to identify patients? Do you screen your docket every morning and try to find patients that might fit this program? People do it every kind of way. But then once you've identified the patient, how do you convince them to be part of the program? That could be a hard sell, and that's a whole part of my presentation. Trying to how do you talk to patients about this program? Ellen alluded to the fact that the area deprivation index is one way that we have determined is a good way to zero in on those neighborhoods that might be suffering from health inequities. Well, we know that chronic care management contributes to overall well-being, decreased hospital stays. We also know that in areas of high ADI, as we call it, these folks are least likely to be getting chronic care management. The opportunity to have proactive, holistic care that's community based, which really pulls in resources and helps folks stay healthy. The other things that are hard about chronic care management is the how. How am I going to find the time? I don't have the bandwidth or the brain space to manage this. There's so much billing and documentation I need to understand. And then staffing. What do I do about staffing? And then can our electronic health record work within the confines of this uh, chronic care management, this way of thinking about patients, this way of tracking our time? Next slide. Well, yes, people do it, and they do it very well. And I've been so amazed by the cleverness of folks and the ways that they've figured out how to get chronic care management to work for them. First and foremost, I think almost universally, people tell us that starting small is a good idea. You can ask your providers or your front office team, who calls here a lot, who's in the hospital a lot. Some providers will say that a hospital stay will trigger an evaluation to be considered for chronic care management. Some use a single diagnosis to start with. Many will suggest that you get a core group of support within your office and clinics, meaning, do you have a provider who's willing to try it? Do you have administrators that are supportive? And that might be even more important than having a doctor willing to try it. And then your clinical staff. Who within your clinical staff might be especially good at this or enjoy this? These are all initial steps to take. Next slide. All right, another thing to think about is accumulating your resources. So I think about accumulating resources, both internal and external. So internal to your office, learn about chronic care management, avail yourself to not only this presentation, but others that we have, say on our YouTube channel. Ellen does a fantastic job. There's a chronic care management playlist that I can't and, offer to you more highly. There are professional society toolkits. Everyone has their favorites. Most of your providers are likely going to be members of either the American Academy of Family Physicians or the American College of Physicians. That's for your internists out there. There are wonderful toolkits that you can either purchase or get if you're a member. And then I mentioned WPS. We have a great many resources, recorded sessions, these sessions, in-person sessions. We like to partner with you if you have special needs. We do all kinds of things to try to make sure that you all have the support you need so that this works well for you. Um, accumulating resources outside of your office, but within your communities. Who are people to whom you could refer? Do you have mental health resources, for example? And think about non-traditional mental health resources. There are church communities with resources, um, family groups, men's groups, even hospices that provide bereavement services, for example. And then think about other partners, food banks and the like, transportation. And then you start collecting these. And there are some best practices on how to collect these resources that are also available to you. Next slide. And here's the thing. We are not just about telling you to do the work. We're willing to do the work too. We need to know that we're making a difference. We actually measure how many claims we get in chronic care management to see if we're doing a decent enough job. But what I understand better than anything is that the engine that moves this is that doctor patient interaction. I still believe, this is old fashioned, I suppose, that that is sacred space, that that relationship is the key to all. When you start to look at your screening results, when you start to accumulate diagnoses, when you develop a treatment plan, when you think about resources outside of your office, all of those things, I can guarantee your providers are already doing. Being able to then translate that into a claim for chronic care management and get reimbursed for doing so, that's wonderful. The data that we have is only important because of the story it tells, the success we might or may not be having, especially in areas where we could be doing better. That is what drives us forward, and that's why this team gets up in the morning. So anything we can do to support you all, we want to do. Questions we take very seriously, and we either try to answer them during the chat, or if you're too shy to give us those questions, then we will certainly respond either formally or informally later.
Okay.
Next slide. Yeah, I think it's up to you now, Ellen.
Yes, thank you, Dr. Valhakis. Absolutely great information that you've provided to us. Mary, go ahead.
Alan, I have a question for you, and I'm not certain if this is something you want to hold on to for a little bit or you'd like to answer now. What provider types can bill for CCM within the HOD?
Okay, Mary, we are going to hang on to that question just for a minute. I appreciate the question, and this is kind of one of the challenges or one of the different things about hospital outpatient billing departments being able to submit a claim for chronic care management in addition to the physician, whether it's a hospital-based physician or a community-based physician, also being able to submit those services. So we do have a slide coming up here in a little bit that will kind of talk about the procedure codes. And so we'll be able to respond to that question at that time. Short answer is, other than limited licensed practitioners, such as a chiropractor or a podiatrist, something along those lines, MDs and DOs, non-physician practitioners, hospital-based can submit for this. Community-based can submit for this. So let's start out here on this particular slide with patients who are eligible to receive these services. You can see here the patient is going to have 2 or more chronic conditions. Now, in the CMS document, it says, and this is a CMS MLN on chronic care management services, it provides a list or an example of chronic conditions, but that's just an example. That's obviously, I mean, it's pretty short. So obviously not all of the chronic conditions that a patient could have. So let's describe what a chronic condition is. That's your next bullet point. It's expected to last at least 12 months for that patient or until the death of the patient. It places the patient at high risk. And you can see here death, acute exacerbation, or functional decline. Now, one of the questions that we have received on this is, does my patient have to be in crisis in order to receive chronic care management services? And the answer to that is no. We just have to meet these requirements. If you have a patient that has diabetes and they have congestive heart failure, both of those are the two chronic conditions, both of those place the patient at that high risk. Now, right at this moment, that patient could be controlled by medication, by additional physical activity, better nutrition, that type of stuff. But the diagnoses still place that patient at high risk. So now let's talk about provider eligibility, and that's listed for you here on the screen. Now, the difference for hospital outpatient departments is that you can submit a claim separately for your clinical staff to be providing these services. This would come in on a UB04 form from the hospital under the chronic care management procedure codes. In addition to that, physicians and the rest of the specialties that are listed here are also eligible to submit. Now, when you're billing for under the hospital outpatient department, you have to be working with a physician. Now, that could be a community physician, that's the patient's community doctor. That doctor could be contracting with you in order to provide CCM services. That doctor could be contracting with your hospital in order to provide after-hour care. Maybe your clinical staff is going to take care of, services happening overnight, on holidays, that type of thing. So under normal circumstances, only one practitioner can bill for chronic care management services. If a hospital outpatient department's clinical staff is providing these services, they also can bill. And in fact, it's a requirement that if the hospital outpatient department is submitting a claim, that physician or practitioner then also has to be submitting a claim. You can see here that you need to meet the Incident 2 guidelines. With a hospital outpatient department, really this is going to be a contract between that physician, whether it's a hospital-based physician or community physician, and that hospital to utilize the expertise of that clinical staff. And then that last bullet point there, it is under general supervision. So that means the practitioner, whether an MD or DO, non-physician practitioner, they're kind of acting in the coach's role. So they're in charge. However, the clinical staff are going to be the ones, for the most part, who are going to provide this service to the patient. If we look on the next slide, what we have here are the different service elements. As Dr. Vlahakis talked about, we do have to have patient consent. There is cost sharing for this particular service. The cost sharing, depending on the procedure code that's submitted, is anywhere from about $12 to $18 a month for that patient. CMS does not have the authority to waive the patient cost sharing on this, but as Dr. Vlahakis mentioned, if we can prevent one hospitalization, then the deductible and co-pay for that hospitalization will pay for approximately 5 years worth of chronic care management services. So because there's cost sharing, you do have to have consent. You can see here on your slide, this can be written or verbal. This consent can be gathered by the clinical staff. It can be gathered by the practitioner themselves, either way. If you're billing under your hospital outpatient department, you want to make sure that you have a copy of that consent also. You want to think about this. If a hospital outpatient department is going to submit for this, and CMS requires that the physician office is going to be submitting for this also, that means in this situation, the patient's going to be getting two different charges. So you want to make sure that you have that consent so that the patient understands that there could be charges coming from two different areas. The next slide there talks about electronic health records. There is certain information such as the beneficiary demographics, allergies, medications that the patient is on, the problem list that needs to be in a certified electronic health record. And we'll talk more about that in just a second. As part of chronic care management, you'll be managing that patient's care transitions. Well, a hospital outpatient department is going to be in a pretty good position to know that you have a patient that has just been discharged, or you know that you have a patient who was in the emergency room today and now they're going home. Well, are they going home? Do they have a community physician? Again, those area deprivation indexes. Patients there may not have community physicians that are helping them with their health care. Services are going to be generally non-face-to-face. Now, that doesn't mean that you can't have a face-to-face service. Some beneficiaries would prefer talking to that clinical staff face-to-face. And if that's okay with you too, then you can certainly do that. But generally, it's going to be non-face-to-face. It's going to be looking at the patient's care plan, which we'll talk about in just a second, and then having a contact with that patient to kind of check in with them. How are you doing today? As we talked last time, we had provided you with instructions on more movement or better nutrition or things that you could do to reduce your pain. So how is that going? You know, have you been doing that? Have you noticed a difference? What do we need to do different? That's going to be the contact that you have with that patient. Again, provided by the clinical staff. And then as part of chronic care management, the patient must have 24/7 access. So what we mean by that is that if the patient wakes up at, 3 o'clock in the morning because they're not feeling well, they take their blood sugar and it's 40. Who do they call? Well, we want them to call the providers who are part of their chronic care management and get with that clinical staff to say, okay, your blood sugar is 40. Here's what I need you to do. Now, what is the goal with chronic care management is so that the patient does not have to go to the emergency room. Now, obviously, you're going to have some patients who are going to need that level of care and need it right then. But with that access to the clinical staff, the contact can hopefully prevent some of those emergency department visits. As Dr. Vilhakis talked about, as I'm sure you guys are aware, if you have been to the emergency room ever in your life, it is never a fun situation, and we want to prevent that if at all possible. So you want to be having a discussion with the patient about what chronic care management is. Again, you got to have the consent. You want to let that patient know, how do I get to the clinical staff? If you're providing services under your hospital outpatient department, who are they going to talk to? Who's going to have access to their care plan so that they can address whatever is going on to the patient? The 24/7 access is not come to the emergency room with everything. It is where they can talk to a clinical staff member who can help them with whatever their situation is going on. And then the last bullet point there, the patient does have the right, obviously, to revoke receiving chronic care management. And if they choose to do that, that revocation is at the end of the month. And so as part of that patient discussion, you just need to let them know how they would do that, how they would revoke this if they chose to. Now, some patients are going to require an initiating visit, and this initiating visit is going to be with the practitioner. This is the MD or the DO or the non-physician practitioner. So let's talk about how this applies then to a hospital outpatient department. You have a patient who you have identified either through previous hospitalizations, previous uses of emergency departments, et cetera, that they would be a good candidate for chronic care management services. So who's the physician under which your clinical staff are going to work? Who's going to provide that general supervision? That provider or a member of the same group with the same specialty would have to determine if they need an initiating visit. So that's going to be new patients, brand new to that practitioner. And again, that's whether it's a community practitioner, hospital-based practitioner. And it could also be patients not seen within the previous year. So again, if they saw them 2 years ago, then they would need to have this initiating visit. And then under that are the services that can count as an initiating visit. So if under the hospital outpatient department or HOPD, you're going to bill for this, you have to make sure and work with that physician's office to verify that they have had that initiating visit. As part of that initiating visit, that practitioner will be talking to the patient about chronic care management and about how that program is going to work. Now, that practitioner can also do a comprehensive assessment and care planning during that initiating visit. Now, we've had some questions on this. Number one, it is only during that initiating visit. It's not a situation where you could bill it a month or so after you saw the patient for the first time. It's not a yearly service. It is only billed on the same day as that initiating visit. And then the procedure code is listed for you there. You'll notice it says it is not applicable to the hospital outpatient department, and that's because a hospital outpatient department is billing for the clinical staff or the facility, not the actual practitioner. So it's an actual practitioner, MD or DO, or non-physician practitioner who would be able to do this service. And what they're really doing is they're providing a comprehensive assessment of this patient, and then they're developing the care plan, which is kind of the start of the whole program. So here's some things to include within the care plan itself. As Dr. Vlahakis talked about, it does need to be patient-centered. And so what we're talking about there is it is specific to Susie. Susie and Bill may have the same two chronic conditions, but Susie and Bill are not the same people. So Susie's care plan needs to be specific for her and her circumstances, what she's able to do, what she'll agree to do, and then Bill's needs to be the same thing. And then we have listed for you here what needs to be in that certified electronic health record, and that is certified based on the CMS regulations on the interoperability. And I believe the latest certified healthcare plan was certified as of December 5th or December of 2015. So that information needs to go in the certified plan. The rest of the information that we're going to talk about also needs to be electronic or needs to be where you can share with other people involved in that patient's care plan. So let's talk about the care plan itself. When we're doing chronic care management, as Dr. Vlahakis talked about, it is holistic. It's kind of everything that's going on with that patient. So we need to identify the problems. Now, this is going to be all of the problems the patient is experiencing, regardless of whether that supervising physician is treating or not. So the supervising physician could be treating the diabetes and the congestive heart failure, but you have another practitioner who's treating the patient's rheumatoid arthritis, as an example. Well, that's still a problem that the patient has, and so therefore we need to include that within our problem list. We need to know the expected outcomes and prognosis. This can be done either on a diagnosis by diagnosis basis. It can also be done based on the overall viewpoint of what is happening with that particular patient. You need to have goals, measurable goals for that patient. So for an example, you have a patient with diabetes. Well, what's the goal for the A1C? You have a patient who has pain because of arthritis. Well, what's our goal for that? Is our goal for the patient to be able to walk across their house 3 times more next week than they could this week? All of that goes into the goals. And part of these goals are going to be what you're going to be doing for the patient. And then part of them are going to be what you're instructing the patient to do. That's one of the real benefits of chronic care management, is that ongoing contact encourages the patient to make changes they may need to make in order for their health care to get better. Excuse me. Under the cognitive function, there's a couple of things to think about here. Number one, if your clinical staff or your practitioner do not observe any cognitive difficulties, the patient or a caregiver is not indicating that there's any cognitive difficulties, you'll document that. If you think there could be some difficulties there, some dysfunction going on, then you want to do cognitive testing. And you need to choose a peer-reviewed testing tool, and there's all kinds of them out there. And as long as it's peer-reviewed, then it's acceptable for you to choose that particular testing. And then, of course, you'll document whatever the test results are, and then that becomes part of your problem. It becomes part of your goal. It becomes part of your care plan. Excuse me. The next thing you want to look at are the functional limitations. Can the patient walk to the bathroom? Can the patient go down the stairs at their house? What's their range of motion? Can they lift their arms over their head to shampoo their hair or to help them take a shower, etc.? So you want to identify, when you're first developing the care plan, where's the patient at now? And then as part of those goals, you want to increase the functional abilities of that patient, and so that would be part of your goals. You want to look at symptom management. We talked about a patient who has chronic pain. Okay, so that's a symptom of whatever disease or illness or injury is going on. How do we manage that? Is that through ordering physical therapy for the patient? Is it through medication? Is it through activities that the patient needs to be doing at home? And so that's part of your instruction to them. And of course, there's other symptoms and things that you could be looking at too. Planned interventions are generally going to be your preventive services. When is the next time the patient is supposed to have their annual wellness visit? Does the patient need a mammogram? Um, uh, how long has it been since their cholesterol levels have been checked? These are preventive services that Medicare can cover. And so, as part of your care plan, you'll need to identify when is the next time that this patient needs to have this, and what are the ones that they need to have. Another thing that you can include in the planned interventions is maybe diagnostic testing, therapeutic services that are going to happen from another provider that the patient sees. So for an example, they're seeing an endocrinologist who's going to perform an A1C in October. Well, you can include that in your care plan. It is a planned intervention. And then that just helps the patient know, helps you know, and the patient know that this is coming up. So you're not ordering it again. And then come November, that's part of the conversation you have with the patient. Hey, you were supposed to do an A1C in October. Did you do one? How did that go? And then what is the difference that that could make within the care plan itself? The next thing that you have there is medication management. As we're aware, Medicare beneficiaries, for the most part, are over age 65. Um, again, for the most part, may see multiple physicians, and those multiple physicians or the hospitalist, if they've been in the hospital, or the emergency room physician, are all ordering medications. So, as part of chronic care management and medication management, you're really assessing all of the different medications the patient is on. Are they the best choice? Is this medication causing a symptom or a side effect that now we have to manage? But if we change to this other medication, then maybe we won't have that side effect. You want to be looking at interactions between medications. Whether the medication is causing a cognitive dysfunction. It, I mean, there's all kinds of things that medications can do. So you're really diving into what types of medications the patient is taking. You're working with other physicians and practitioners um, working together to see if the medications that the patient is on based on their problems are really the best choice for those. Then you want to assess the patient's environment. Is the patient homeless? You know, um, that's going to make a big difference in the care plan that you're providing to the patient. Does your patient live in what's called a food desert? You know, where either because of lack of transportation or other reasons, there isn't a good grocery store that has the good fruits and vegetables near them. So you want to be looking at that. You want to be asking them questions about the safety, the physical safety of their home. Are there a lot of stairs that they have to go up and down? You know, is there heat? Is there air conditioning? All of that kind of stuff. In addition to that, you want to be asking the patient about their mental and physical safety within their environment. Do they have a son or daughter who's living with them that is abusive? Do they have a son or daughter living there, or grandchild, could be too, living there that's stealing their medications? That's questions that you want to ask, and then that's part of your care plan. How can we make, how can we affect this? In some cases, you know, may not be able to change it all the way, but you know, that's going to be part of what you're talking to them about. Under caregiver assessment, well, the first thing that we want to know is, do they need a caregiver? Some of your patients will, some of your patients won't. If your patient does not need one, then you simply document that and you're done with that part. If they need a caregiver, do they have one? And if they have one, how able is that person to be able to take care of that patient? Do they have the physical abilities to help that patient bathe and help that patient move? Do they have the mental abilities to help that patient with medications and understanding the goals and that type of thing? And then, of course, that's what you'll document. And then the last one there, the social services, this is what Dr. Vlahakis talked about earlier in knowing what resources you have within your communities. And we've got a slide at the end of the presentation that can help you with some of that. But it's identifying the Meals on Wheels in your area or a BART transportation that can help older patients get to where they need to go. Excuse me. And then underneath that, it talks about the care plan. You need to update it as needed. And what that means is that if the patient has identified a new problem, then that needs to be incorporated into your care plan. And then you now have an updated care plan. If there's no changes to that care plan, but you're still monitoring, you're revising as necessary, etc., then you're including that information, but you're not actually doing an update to that care plan, a formal update. You do have to review that care plan at least yearly. And again, that can be the clinical staff working under the supervision of that practitioner. And then you have to share the care plan with the patient or their caregivers. Now that can be through a patient portal if you have that, and if the patient agrees to accept it that way. If the patient says, no, I really want a hard copy, or the caregiver does, then you do need to provide them with that hard copy. You also want to be talking to other practitioners or sharing this care plan with anyone else who's involved in the patient care. And then the other section down there could be those social services. Number one, if the patient agrees for you to release that. And then number two, if that agency needs that information, on that patient condition. So let's talk next about what care management actually is. Care management is the monthly service that you're providing to that patient. This is revising the care plan. It's implementing the care plan. It's monitoring the care plan. It's having that contact with the patient. So what you want to do is document all of those things that you've done. If you spent 10 minutes going through the care plan and reviewing that care plan, and then another 10 minutes talking with the patient, you have 20 minutes. If you then spend another 5 minutes documenting that contact, you have another 5 minutes. All of that time that you're spending goes into the submission of the chronic care management services. You can see the activities there, determining patient status. This is going to be asking if anything has changed. Again, how are they doing on the goals that you have set for that patient, etc. And then identifying the staff who provided the service. Again, we're talking specifically about hospital outpatient department billing. So that's for the most part going to be your clinical staff. It can also be your practitioner staff. Again, community, hospital-based. If they have not provided the amount of time for them to bill separate, and I want to be careful about how I'm wording that, because in a hospital outpatient department billing, the clinical staff of the department has to provide the time required for the procedure code, and then they can bill for that. You can submit that to Medicare. The supervising physician, because of the time that clinical staff have submitted, can also submit a charge because they were supervising for that clinical staff, employees of the hospital outpatient department. The other way that you kind of identify who did the service, if your hospital outpatient department only had 15 minutes in that month, if the practitioner had time, that practitioner time can build into that clinical staff time. Another question that we have received concerning who can provide the service has to do with residents. A resident is not going to be the supervising physician, and a resident services are only, well, Medicare reimburses the teaching physician for resident services only in two circumstances. One is under the primary care exception, and chronic care management does not fall under that. And the second is under the teaching physician guidelines, but the teaching physician has to be physically present with that resident while they're doing the service. Because this is a non-face-to-face service, we don't anticipate that that's going to happen very often. So what do you do with your resident time? You include it in with that clinical staff time. And then the best practice is to submit at the end of the month so that you can capture all of the activities that you've provided. So what are the procedure codes then that you can submit? Well, for a hospital outpatient department billing, there's only the one procedure code, the 99490, which is the clinical staff procedure code, and it's the first 20 minutes. The practitioner can also submit that 99490 procedure code when the clinical staff of the hospital have met that 20 minutes. The other thing that, and we'll kind of talk about this one here, the other thing that you want to look at is, are you as a hospital outpatient department doing the chronic care management service, or are you acting as a consultant or a contractor for that outside practitioner? So let's talk about the difference between the two, because it makes a difference in how you submit for this. If you are providing this service and your patient has contracted directly with you in order to provide this service, you're the place where they go for care. You're working with either a hospital-based physician or with a community physician, and you're providing the service, then you can submit this procedure code. If your hospital outpatient clinical staff are working under the community physician, acting as a care management organization, acting as after-hour care, etc., then your organization would not bill separately for this. That time would kind of go into that practitioner's time, either for them or their clinical staff. So just some additional information. Again, practitioner time can count toward the clinical staff time. Clinical staff, however, cannot count toward the practitioner time. And the time has to be met in full, which is at least 20 minutes. The information where this was published, I think, was in the 2019 OPPS final rule. And the only procedure code that they're mentioning within that final rule is the 99490. The final rule does not indicate that you can build the additional time procedure code, each additional 20 minutes or 30 minutes, depending on your procedure code. But there's nothing in there that says you can't. And I cannot find anything published by CMS that says if you had 40 minutes for the patient, that you could not bill that each additional procedure code into Medicare. So the next thing that we're going to do here in just 1 second is we're going to open it up for questions. We have about 30 minutes left, so we do want to provide responses to all of your questions. What we have up on your screen right now, though, is a QR code that will take you, if you put your smartphone up to it, will take you to a survey on this particular presentation today. We're very interested in your feedback. Um, we want to know, is this the information that you needed? If it is, and you want to give us a 5 across the board, that's fantastic. If the information lacks something that you need, then tell us that. And then we'll make sure that we get you the information that you need. Now, because we believe that these surveys are so important, you have a link here, you have a QR code. When you leave the webinar, you're going to get another page that says you're getting ready to leave WebEx, and it's going to take you to the survey. It will have kind of a yellow triangle up on the top. It's not a spam thing. It is taking you to the survey. Again, your survey responses are very important to us. Okay, Mary will go ahead and ask for questions then.
I've placed a reminder in the chat feature that is, in order to submit a question, you need to use our chat feature during this webinar. Please use the drop-down arrow and select all panelists. We do not recommend, or we don't want you to use host or host and presenter. Instead, please select all panelists. Thanks so much. Ellen, as of now, we have no questions, but I'll continue to monitor the chat.
Okay, now, Mary, I can just see, since I'm sharing my screen, I just kind of see things pop up real quick. I thought we did have a couple of questions. Did I read those wrong?
Ellen, those are questions that I've handled one-on-one, questions about how to get the handouts and such.
Okay. You know, we want you to be able to submit for these services, obviously. As Dr. Valhakas talked about earlier, the value to the patients by using these services is really just fantastic. It formalizes what's already happening. You know, Dr. Valhakas talked about that your frontline staff, if you're representing a physician office, your uh, the the people who are answering your phones at your hospital outpatient department, they're going to know people who are calling in often. So by using this program and kind of structuring based on the Medicare rules, you can receive reimbursement for that. So it's a value to your offices in addition to being such a great value to the patients. Mary, I see your hand is up.
Yes, we did receive a question, Ellen. This one is from Hannah. The example you gave of time, 10 minutes developing a care plan and 10 minutes discussing with patients. Can you give more examples, such as does phone calls between other providers count?
Yeah, and I apologize for that delay. I had to find the unmute button. Yes, it does, because that's part of implementing and monitoring and establishing that care plan. So if you need to contact the cardiology office to find test results, if you need to contact them, you know, to say, hey, my patient has just reported that they're having this particular symptom. This really kind of seems like it's more cardiology than, you know, whatever my specialty is. And having that conversation, yes, you can count that time. Mary, I see your hand is up again.
Right, we have a couple of more good questions, Ellen. This one is from Amber. Amber said that you mentioned that the cost is $12 to $18 a month, but she's wondering in the beginning of the year, does it actually go towards the deductible, meaning they would owe then around $59?
And you are correct. There is cost sharing on that, so that means that the patient would have deductible and co-insurance applied for that. So the allowed amount, if it went to deductible, of course, would go to deductible, and then once patient's deductible is met, then they would be able to only have to do the copay. Very good question. Thank you.
The last question, Ellen, is really kind of related to the one we just talked about from Amber, and this one is from Cheryl. Cheryl's wondering, what is the reimbursement to the Hospital Outpatient Department? And I believe, based on what Amber said, it would be around $59, if the deductible had not been yet met, or else the cost sharing of 12 to 18 a month. Do you want to expand on that at all?
Actually, no, I don't. And the reason why I don't, it's not that I don't want to answer your question. I am not as familiar with the billing and the patient responsibilities under when you're using the UB04 to submit your claim to Medicare. I know if you're using the 1500 form. So what I would ask you to do with that question for me, if you would, and we will make sure that we're responding back on that, is to submit that to our mailbox. And any follow-up questions you have for the next 10 days, we can take that. But it's WPS period GHA period education at WPSIC.com. And then I will find out for sure how that reimbursement would go back and what that reimbursement would be. Thank you for the question.
And Ellen, I've placed that email address in the chat, and just along with a reminder for folks, if you are sending a question, presentation related question, that is, for a period of up to 10 days, please do send that to the email that I've placed into the chat feature. And if you would please place today's date, April 20, 2023, CCM HOPD in the subject. That will speed things up a bit. And we'll make certain that that information gets off to Ellen so she can respond appropriately. I do have one other question that came in.
Sure.
This is from Carrie. Ellen, can you please clarify charging for this in an RHC? Early in the presentation, it said RHCs could submit this charge, but a later slide said it couldn't.
Hey, the information for today's webinar is concentrating on submission by hospital outpatient departments and provision of this service by hospital outpatient departments. We just completed a webinar probably within the last month. I don't have the date right in front of me, but within the last month, specifically for rural health clinics and federally qualified health centers, that is available in our YouTube channel, under the CCM playlist. You can also access that by going into our website, the WPSGHA.com, choosing the Topic Center Training, and then we have a section on there for encore presentations. And so the webinar that we did specifically for RHCs and FQHCs is there. So when we talked about the RHC, FQHC not being able to bill for this, let me go back in my presentation here real quick. There's one place in here where an RHC and an FQHC cannot bill for transition. I'm not saying they can't bill for transitional care management. They can, but it's not an initiating visit. But take a look at that webinar, listen to that. And then additional questions, you still have the email address that you can send back in to us. Okay, Mary, any additional questions?
There are no new questions, but I did place a link to our Encore presentations webpage out in the chat. And this is where you can find not only the recording for the Rural Health Care Federally Qualified Health Center Chronic Care Management webinar that was held on March 16 of this year. You can find recordings for many of the other live events that we have held. So if you're interested in that RHC or FQHC recording or any other recording that we may have posted out there lately, you can take a look at the information on our website. And again, the link is included, or I placed the link in the chat feature. There are no additional questions at this time, Ellen.
Okay, wonderful. Yeah, our YouTube playlist really kind of breaks down a lot of the information that we've talked about. We have a separate uh, YouTube video, short YouTube video, and a webinar presentation and encore on care management, on care planning. There's just a lot of information out there. So before we end today, one of the things Dr. Vlahakis talked about and that I mentioned also is knowing the resources that you have available within your area to assist your patient. Like we talked about, Meals on Wheels. Is there a local YMCA that can help the patient engage with people so maybe their depression is not as bad, or maybe it encourages them to get out more, etc. So what we have on the slide right here is that if you're wondering, whether or not a particular type of service is there, you can call 211. There's a program or a menu that you would need to go through to identify your location, etc. But this is a way that you can start to find those outside and community resources that can really help you in taking care of your patients. What we have on the next two slides, this one is for jurisdiction 5, and it's the website address for the 211. Now, Missouri's does not say 211, but it's still the same information. So we provided you with the website there. You can take a look. Your clinical staff can take a look, see what additional resources you may have available for your patients. And again, the goal is taking care of that patient. It is identifying, if they can improve either with the problems that they have or with their quality of life also. And then on this slide, we have the jurisdiction 8 information, the two websites for Michigan and Indiana. And again, I know if you guys are anything like me, I attended a great training session and then I go back and I start thinking about it and then I come up with additional questions. Or I'm training someone else and then they're, have questions that I don't know the answer to. This is the website address that Mary placed within the chat. So we can take follow-up questions through this through May 1st. And again, include the date and CCM HOPD within the subject line, and then it will be able to get to us. So Mary, I'll ask one more time if we have any questions.
There are no new questions, Ellen.
All right, wonderful. Well, thank you all very much for attending today. One of the other documents that you have is called a Timely Topics document. There's lots of different pieces of information in there. Chronic care management is one. We have information in there on depression screening. We also have a section in there on our surveys, both the one that we're asking you to do for this presentation today, and then also on different areas within our website. The surveys are part of what our reporting is back to CMS. So you to be able to have that voice and to share with us what your opinions are. We have information out there on a recent CMS identification of a problem Evidently, CMS is encountering a severe issue where providers are denying services and treatments to Medicare beneficiaries when they have an open Medicare secondary payer record. So what that means is the Medicare records show that the patient is secondary with Medicare and there's another insurance that should pay first. And these providers and practitioners are saying, well, no, I'm not going to treat you. You can't do that. You know, there are requirements in order to treat patients, and there's information there for you on that timely topic document. And then the last thing we had there is just concerning our learning center. We pay attention to the surveys. You know, I realize you've heard that word quite often today, but we pay attention to the information that you provide us back. Well, part of that information that has been provided in previous surveys is that using our learning center was really kind of awkward. And there were multiple steps that you needed to do to get registered, to attend, to get your handouts, all of that kind of stuff. So the Learning Center is now gone. We have determined that using WebEx in order to do the registration, in order for you to be able to get your handouts, supplies everything that we need, and it supplies everything that you need. You will be receiving an email coming back from WebEx that will say thank you for attending. As part of that email, your certificate or language that was used in the previous certificates of attendance we used, that language will now be in that email. So then you can use that email in order to receive your additional, I'm sorry, your CEUs, continuing educational units. I got lost there for a second. So the Learning Center is now gone. You don't have access to it anymore. We have taken all of the information that was in there, and it is either in our YouTube channel as recordings, the encore recordings, or we have written documents, written resources that we have placed out on our website. So we want to thank you for sharing that information with us so that we were able to make the changes in order to make things better for you. So that's all the information that I have for you today. I want to thank you very much for your attendance. And so we'll stop the webinar at this time. Have a great day, guys.